Sure. All right. Good morning, everyone, and thank you very much for joining us today for another Aorta chat as part of the Aortic Disease Awareness Month campaign with TSMA. My name is Adam Ahmed. I'm a fourth-year student at CUNY. We are joined today by Dr. Megan Chung. She's a first-year resident in the Integrated Cardiothoracic Surgery Residency Program at Columbia University. Dr. Chung is originally from Arkansas and attended Columbia University College of Physicians and Surgeons for medical school. There, she conducted clinical research under Dr. Hiro Takayama. Their group recently published a wonderful paper in JTCVS titled Utility of Structured Follow-up Imaging After Aortic Surgery, which we will be discussing today during our call. Dr. Chung, thank you so much for joining us. How are you this Sunday morning?
I'm doing great. Thanks for inviting me to speak with you all today.
Thank you. So before we get into the details of your paper, could you tell us a little bit about your inspirations for becoming a cardiothoracic surgeon?
Yeah, sure, I'd love to. So I came into med school pretty open in terms of what specialty I'd be interested in. I had shadowed a few physicians in like college and in high school, and one of them happened to be a cardiac surgeon. So I'd seen a couple cabbages coming into medical school, which I thought was really interesting, but of course I didn't really know anything about what was going on back in that time. Um, I stumbled into Dr. Takayama's research group pretty early on in my first year because he gave like a week, we had a weekly research seminar where they would invite speakers from all different departments and specialties to talk about their research to first year students. And he just, if you guys know Dr. Takayama, he has a very great stage presence and energy, and he's very inspiring. He also was very welcoming of first year medical students doing clinical outcomes research with him. So I reached out to him because it's pretty common at my medical school to do research the first summer before second year. And he welcomed me very warmly, which was great because I had never done any clinical outcomes research. Like all my research experience before medical school was like in a chemistry wet lab, but I wanted to try something different. So um, I worked with him over the summer, still was pretty open to a lot of stuff, but was able to shadow him in the OR a couple times. Then in my clinical rotations year, I started with my medicine rotation and I quickly found out that that I would like to do something a little bit more hands-on, a little bit more active. Um, and on my surgery rotation, I really loved that with surgery, your patients, you don't take patients to the OR unless you think you can really prolong their life or really acutely help them from pain or, anything else. So I really like the feeling that you could really impact a patient's life, like in the span of a day, really. And I was really into the hands-on technical aspect of it too. Um, so after my rotations, I was pretty committed to surgery, and within surgery, I really liked the anatomy of the cardiovascular system, the physiology of it, hemodynamics of going on bypass and coming off. Um, and I just thought the procedures were some of the best procedures that humans can do in the hospital. Um, yeah, so I had a really great mentor early on. And Dr. Takayama really supported me throughout the whole process. He never pressured me to do cardiac surgery, but um, I I can't say I don't know where I would be if I didn't meet him pretty early on in medical school. So
That's incredible. And you two obviously published a lot of things together. So with yeah, could we get into the paper that you recently shared in JTCVS and kind of walk us through your main findings?
sure, yeah, I'd love to. So this project, came out through an interest of a lot of the research that we did was just looking at like what we do in the hospital and how does that impact their in-hospital outcomes and then long-term outcomes of mortality and reintervention rates. 'Cause one thing I was interested in is like what happens to patients after they leave the hospital. And Dr. Takayama and I decided to look into all the patients uh, that had aortic surgery for aneurysm or dissection at Columbia. Um, in the last 5 years, I think we went back to 2017, and see what happened to them like in the follow-up course. The Columbia Aortic Centers, which is kind of like our outpatient center for all things aorta, they started a structured surveillance follow-up program in 2017 based on some guidelines at the time, which recommended asymptomatic surveillance imaging after aortic surgery. And I can show briefly some of the figures from our paper. I like this. So we looked at 643 patients in this cohort. We excluded, obviously, patients with in-hospital mortality couldn't be followed. Endocarditis is kind of a completely different subcategory. And then thoracoabdominal aorta, also a little bit different when we work with our vascular colleagues on those patients. But overall, we had 559 patients in this cohort. And our follow-up guidelines were such that if you had an aneurysm, we encourage a CT or MRI at 6 or 12 months postoperatively to assess, if there's any growth of the unoperated aorta, or if there's any other, incidental findings at that point. And if there isn't any concerning findings, we would individualize the follow-up after that. So, if there's no growth and you just had like an ascending and everything else looks fine, we may just follow up in like 5 years with a routine scan. Whereas dissection, obviously, we have a lot closer follow-up for those patients just because a lot of them have residual tears or they're a little bit sicker, et cetera. So these patients we followed a little bit more closely with at 1 month, 3 months, 6 months, and 12 months postoperatively. And again, after that point, we would individualize that afterwards. And one thing that kind of limited our analysis, but also was a pretty important finding for us, was a pretty low compliance rate with this. So the percentage of the cohort that didn't end up having a follow-up scan really within the first year or two, at which most of these follow-up imaging is recommended. It's only about like a third of patients actually came in for that, and we can talk more about that later, but that was a kind of major finding, was that even with our guidelines and the implementation of this routine follow-up imaging program, we weren't actually getting a large percentage of our population for various reasons. Nevertheless, of the patients who did come in for asymptomatic scans, my team and I, we work with radiologists and we reviewed those images for this study to see what did we actually find on these images, and did the patients that end up coming in for a scan end up having different long-term outcomes. Yeah, and the findings, because this was limited to 2017, we still are trying to see what the impact of long-term outcomes might be. We actually found a significantly increased reintervention rate in the patients that had follow-up, even after propensity score matching for baseline differences that may make those patients different from those who can't get follow-up or didn't get follow-up. But we didn't yet see a survival benefit. We do see, a little bit of divergence here. You can see the Kaplan-Meier curve, red patients being the patients with follow-up, blue being those without follow-up. And they are starting to diverge at 3 or 4 years. It's not significant yet, but we're going to follow up that data as time progresses.
Awesome. Thank you so much for taking us through that. You mentioned that in your analysis, reintervention rates were nearly 3 times higher in the cohort with surveillance. Do you have a little bit of information about what the most common reasons for reintervention were?
Yeah. So I don't have the numbers like off the top of my head, but for the most part, almost all of the reinterventions were in the patients that got routine follow-up imaging were for interval growth on CT scan. And I think the reintervention rate was significantly higher, maybe obviously in patients with dissection compared to aneurysm. So a lot of these patients, they came in with the type A dissection, acutely got aortic surgery with us. We followed up in 1 month. we saw interval growth of, distal to our our original repair. And we took them back for usually a TVAR, especially in this post 2017 era. But we would count that as a reintervention for that cohort. I think in the patients that didn't have routine follow-up imaging, they may have gotten, these patients, if they had gotten a CT scan for symptoms or like chest pain or like anything else, we wouldn't call that as a surveillance scan, but for those patients, if that was the only follow-up imaging that they had, they were in the no follow-up cohort. And those patients also would get reinterventions for findings on those scans. So for the most part, it was interval growth. There were a couple patients where on the routine surveillance scans, we saw pseudoaneurysms. For the most part, we would follow those over time, but I think there were one or two patients whose pseudoaneurysms kind of started growing and they may or may not have started having symptoms. And so we took them back to the OR to fix that.
Wonderful. I think it's very cool that how much multidisciplinary collaboration you have. You have the aortic, cardiovascular, and the vascular surgeon kind of trying to find an approach that works best.
Yeah. Especially as aortic surgery is going to become more and more endovascular. I mean, we've seen that clearly in the last 5 or 10 years. And we can't do this without our vascular colleagues. So at least at Columbia, we have a very close collaboration.
Absolutely. And you kind of started talking about it, but the one of the limitations of the study was low patient compliance with the follow-up. We were wondering, well, what do you think might be major challenges, not just in this cohort, but just with patients getting follow-up imaging after aortic intervention? So how could we kind of circumvent that?
Yeah, super important question. I think at least from our experience, one thing that probably applies to a lot of like major aortic centers is that we're a very large referral population. So a lot of our patients live in Jersey or like upstate New York. And so, there's some limitations in terms of like distance and coming to us. We do give them the option of getting a scan locally around them and having the images sent to us for our review. And they can still follow up with us. But, that just adds a level of complexity, and especially for patients who feel asymptomatic and, feel that their repair is, kind of one and done, especially for the aneurysm cohort. And part of that is, we do have a practice of emphasizing the importance of routine follow-up. But, at the time that we started the surveillance program in 2017, there actually wasn't that much good literature on like why we should do routine imaging. There's actually a lot of literature that shows that after you repair an aneurysm, if you really get the whole aneurysmal segment, your repair should be stable for the patient's lifetime, more or less, and there's no need to do imaging. So there's a little bit of conflicting data on that, and I think that generally has been a lot of the philosophy behind aortic repair for aneurysm. Now that a lot of the guidelines that recommend imaging, a lot of the data is from just observational studies that look at reintervention rates after aortic surgery, but not really looking at these asymptomatic scans because we just historically haven't gotten them. So, one thing that, we wanted to publish with this paper is, hey, we are doing these scans and we are finding things on them. So honestly, just having this paper out and this data, accessible to surgeons and patients could be one way to help, increase that compliance rate. Just saying, hey, this is what we can find, and we encourage coming in because we could, prevent a catastrophe if we are finding some interval growth on our scans or a pseudoaneurysm, etc. Our study, we also looked at, baseline characteristics of patients who came in for follow-up and didn't. We look at things like insurance status, distance to hospital, and then DCI, which is like a distressed communities index, which is at least in a lot of surgery literature, I think other literature as well. It's kind of like a good proxy for socioeconomic status by zip code. And those weren't different. All three of those things weren't different between the cohorts that did and didn't get follow-up. We have a pretty complex patient population at Columbia and in the city, which isn't very representative of most of the United States or anywhere else in the world. But we it would have been interesting to have found a difference, in patients' backgrounds who do come in and don't come in. But we didn't find a statistically different cohort in terms of that. Yeah, so I would just say, how it could just be up to, surgeons and providers just stressing that, hey, we should follow up after surgery, maybe speaking more with our cardiologist colleagues who also have a close relationship with these patients and are more kind of like a primary provider for these patients as well. But hopefully as more and more centers adopt, surveillance imaging after surgery, this can be a more like known and established phenomenon.
Yeah. And it's good that we now are starting to get more data as people
Yeah.
publish their findings as your group has. And kind of looking forward to the future a little bit, if we could predict, do you think, what do you think are, with regards to imaging technology, do you think we might practice in the future where MRI might start to be prioritized over conventional CT? You mentioned you use both in your cohort. What are your thoughts on that?
Yeah, this is a super cool question. So we use the gold standard in terms of like aortic imaging is CTA, like with contrast gated. Of course, that comes with a lot of exposure to radiation, especially if you're getting a scan like 4 times a year. And if you're a younger patient, if you have kidney disease, all these things we think about, like, should we just follow up with the MRI? The images aren't as good. It's a little bit harder and fuzzier to measure the aorta, especially you have one CT scan and the next one's an MRI, the margin of error between measuring those, it's a little bit larger than if you just got the same imaging modality every time. But I think there's a lot of really exciting stuff with MRI coming up. I think some centers have gotten access to like 4D flow MRI, which can show you, using contrast and time, spatial resolution, and a lot of like physics that I don't really know much about. You can see how like flow through the aorta is visualized and quantified even using MRI in a way that we're not able to do with CT at this time. I think this is huge. There's a few like small sample size studies that kind of show that this could be really useful in aortic surgery. Like if you have a certain like flow pattern that can predict like growth or aneurysmal growth or future dissection even in some patients, um, especially with more AI and ML coming into radiology and in the medical field. I think this could be huge. Right now my paper is advocating for, we shouldn't personalize imaging and everyone should get imaging. But if we're able to, especially with like pre-op and post-op 4D flow MRI, stratify risks based on, what their flow patterns are looking at, like, I think that could completely change, what follow-up would look like and what even surgical planning, before we even take them to the OR, we can even decide how much aorta to repair based on like what looks like it could be a future risk for aneurysm and dissection in the future. I still think that's pretty far away. Like at least at Columbia, we don't have the 4D flow MRI in clinical use yet. I think we might be starting doing some research on it, but it's very expensive as well. So that's another, con to it. But hopefully, if access and cost, change over time and we get more AI integrated into our program, I think that would completely change everything. But we might be a little far out from that.
It's an exciting time for us to be entering the field, is what it sounds like.
Yeah.
Right. And much of the tuners, the listeners that have been tuning into this series has been medical students, many of them aspiring cardiothoracic surgeons. We were wondering what's one piece of advice you wish you were told when you were a student?
Oh yeah, good question. Uh yeah, I this is actually a funny quote that I learned recently from Dr. Smith, who's a chair of surgery at Columbia. He actually published a book last year, and I ferociously read it the night before my interview when I found out that he was going to be interviewing me on my interview for the I-6 program at Columbia. Um, One quote that he ends with is along the lines of, cardiac surgery is not that hard, but being able to practice cardiac surgery is hard. It's like just in terms of getting into this, specialty from the beginning. So I would say, you know, if if this is what your passion is, if this is what you can't imagine yourself not doing with your life, and if you're inspired by the patients that you're seeing and the problems that we're facing, don't give up. It's there's a lot of ways to get into cardiac surgery. Um, it's a pretty long pathway, but um, it requires a lot of resilience and grit. Um, Even after you start residency or start your practice, like you're still going to need a lot of resilience in your career because it's quite demanding and challenging in terms of like the patients that you're dealing with and the complications that can come out. Um, One thing that I kind of mentioned earlier that I'm really grateful for looking back on it is having such a great mentor. If you can find a mentor, early on, you know, or even wherever you are in the process, it's never too late to find a good mentor and a role model. Um, just finding someone that can believe in you and advocate for you and find the opportunities for you, it can make a huge difference. I know it can be pretty hard. I do feel very lucky that we worked with Dr. Takayama really early on in my career, but there are a lot of opportunities to find mentors. Like a lot of these major conferences like AATS and STS have scholarship programs that will, pair you with a mentor, or you can just get a coffee chat with them during these conferences if you're able to attend. Or I know some people who don't have a strong cardiac surgery program at their home medical school, they'll just like email or reach out or call attendings at nearby, facilities or other hospitals. Or even like they don't even have to be nearby. You can just like Zoom with with surgeons now and there are what I found cardiac surgeons are very open to mentoring, passionate and driven medical students who are interested in their specialty. It's um, you have to display, you know, consistent hard work. But I do think cardiac surgeons can identify that and want to help the medical students that present themselves as such. So keep working. It's a long process. I remember getting through it. I just barely made it out of the whole medical school application cycle, but um, it can be very rewarding.
Thank you so much. And I think it's really helpful for us to hear advice from someone who can closely relate to the things we're going through right now. And uh, you know, we're it's an exciting time, but it's also a stressful time. But
Yeah.
it's good to hear that there's a light at the end. And to our viewers, we are going to be hosting Dr. Takayama next Sunday, so we'll be able to hear from him as well and kind of follow up this great discussion. Uh, Dr. Chung, it's been great to talk with you. We are approaching the end of the interview, and I do want to be respectful of your time. But do you have any closing remarks for our listeners or people who tune in later to the recording?
Oh, closing remarks. Sure. Well, for any medical students or, even I don't know if there are people before medical school that watch these as well.
Probably.
Yeah, feel free to reach out to me. I don't know if you're welcome to give them my email, or it might even be on the Columbia website. Feel free to reach out to me if you have any questions. Um, like I said, I just started residency, so I still remember what the whole process is like. Um, Happy to talk about my experience, not just at Columbia, but you know, throughout the whole process as well. Thanks for tuning in. Obviously aortic disease, and it may not be the most like highlighted or sexy disease in like the media, but it's really great the work that Autumn and TSMA has been doing to increase awareness, and thank you so much for inviting me to speak.
Thank you. Have a great rest of your day and good luck. Take
Thank you,
care,
you
everyone.
too.